So everyone, just to introduce myself, good day, I'm Casey. I'm a speech therapist and lecturer at Sefaku Makato Health Sciences University. The research that I'm presenting to you today is part of my doctoral study, and that was completed with the University of Pretoria. Still in the process, but almost done. And this research paper specifically explores children with SAM's feeding, swallowing, and communication characteristics. As we did the study during the COVID-19 pandemic, we noted some helpful insights that give us a little bit of an idea of what the effects of the pandemic were on the healthcare system, and also ways that speech therapists might support the SAM management team. So, one of the things I had to get to the bottom to before I started my research was, what is severe acute malnutrition? So severe acute malnutrition is a form of malnutrition. Malnutrition includes overnutrition and undernutrition, and specifically severe acute malnutrition is the most severe and life-threatening form of being underweight. So according to the World Health Organization, severe acute malnutrition is diagnosed by three different criteria, or three possible criteria. Firstly, the child's weight for height might be 3 standard deviations below the norm. So that is, the red arrow at the bottom below the black line. You also might see presence of nutritional edema, or the child's MUAC, mid-upper arm circumference, might be measured at less than 115 millimeters. So in South Africa, we have quite a challenge with treating severe acute malnutrition because it commonly co-occurs with TB and HIV. A high prevalence of HIV is seen with our children who are treated for severe acute malnutrition. In the Eastern Cape, recent evidence showed 40 to 50% prevalence of HIV in children treated for SAM. So HIV is also known to negatively impact a child's mortality rate as well as their nutritional recovery. Later disease stage HIV is known to prolong SAM recovery and make it more difficult. And in a similar way to SAM, we find that HIV poses a risk for children's neurodevelopment and physical growth. And so when we put HIV and SAM together, we become very concerned for our children's development and health. On the other side, TB increases a child's respiratory rate, it makes them short of breath, and that is going to impact their ability to coordinate their suck, swallow, breathe pattern. And so we become concerned for risks of oropharyngeal dysphagia, or OPD. Research has shown us that when you combine HIV and TB with SAM, you have a much higher mortality rate. And so now when we are adding another respiratory illness, which is COVID-19, to the mix, we are becoming greatly concerned for our children's health and, when they survive, their future development. So recently, the research perspective has started to change. It's changed from a medical focus on survival to prevention, and now they're looking more at nutritional outcomes. But what we've seen is, through timely intervention in South Africa, using World Health Organization 10-step guidelines, we've seen a reduction in our case fatality rates from 30 to 40% to about 15%. But the recent research is showing that it's great these children have survived, but they're now experiencing disrupted neurodevelopment, and they're having long-term developmental outcomes that show cognitive and motor deficits. These delays have a negative impact on educational outcomes, future employment, and mental health, and that has been shown by research internationally. It's therefore very important that we start to address and prevent SAM as early as possible so that we can prevent the burden on the child, the family, and our communities. So the COVID-19 pandemic has impacted our communities extensively, specifically financially and their nutritional support. Social distancing has also sparked fear, and so now there's reduced attendance, so that prevents monitoring for malnutrition. And so now we are even more concerned about the well-being of our children again. We've established that cognitive and motor deficits exist for children with SAM, but there's no research on their language development, And there's no research on their oral sensory motor skills for speech and for swallowing. There is in terms of failure to thrive, but not specifically SAM. So we've used an exploratory collective case study to describe the swallowing, feeding, and communication characteristics of toddlers with SAM during their inpatient nutritional rehabilitation. Because there's a lack of information published from a rehabilitation perspective, we undertook this collective case study to explore if there is even a role for a speech therapist with this population. And so this information is mostly qualitative observations that we've drawn up. And this is a proof of concept for motivation for future research. And so that is why it's so important for us today to share it with you, is because we want you to know there is a need for future research in this population, particularly for rehabilitation specialists. So these case studies were identified as part of a larger study which ended in December last year. And the specific date of this data collection was the 16th of June. So all cases that we identified met the selection criteria on that specific day, on the 16th of June, at a tertiary hospital in Gauteng, South Africa. At the hospital, they have a full multidisciplinary team. Doctors, nurses, speech therapists, OTs, physios, audiologists, social workers, dietitians, and psychologists are available. The treatment follows closely according to the World Health Organization 10-step guidelines. And the dietitians monitor the children in the pediatric wards on a weekly basis for any form of malnutrition, which is wonderful. So our data collection specifically used bedside assessments that were conducted while the children were in their rehabilitation phase of nutritional recovery. So what that means is the children were no longer considered acutely ill by the doctor, and they did no longer have life-threatening risks or threats for their health. So our data collection was an interview for background information. Communication assessment was with the Rossetti Infant Toddler Language Scales, and the feeding assessment was with the Schedule for Oral Motor Assessment, with additional considerations for aspiration and disruptive feeding behaviors. We identified 3 participants. Their mean age was 1 year 4 months. Their birth weights were all normal and, interestingly enough, all above 3 kilos at birth. And their diagnoses were severe acute malnutrition. But unexpectedly, when we went looking for children with SAM in the ward, all 3 children that we found were also diagnosed with HIV and TB at hospital admission. Their risk factors that they present with is informal housing. And then, despite their monthly incomes being above the lower bound poverty line and above the food poverty line, these mothers all reported regular food insecurity. Protective factor in their household is that no one is abusing substances. So this is the significant medical information. It is noteworthy that the mothers all reported a short breastfeeding duration, which is usually encouraged to continue by the clinics. At the time of data collection, although speech therapy services were available at the hospital, the speech therapy department was not referred to. For the results of the feeding assessment, we first highlight the mothers did report disruptive feeding behaviors in their interviews. And most importantly, the toddlers were refusing their food at the beginning and middle of their meals. And this should only be happening at the end when they're expected to be full. The high frequency of food refusal is consistent with SAM. It's been reported by a number of dietitians around the world. Children 13 to 18 months should be able to sit or stand independently while they feed. But 2 of our participants had difficulty and required support to sit and feed, which indicates inappropriate and delayed motor development, which is also consistent with research about SAM. Then, at their age, toddlers should be able to self-feed with adequate lip closure, and they should have both lateral and vertical movements of their tongue for rotary chewing, and they should have no food loss when they eat. However, our toddlers all had difficulties with eating solids and purees, and they should be able to tolerate all consistencies at this age. Our third participant had difficulties specifically with liquids, showing uncoordinated swallows, multiple swallows to clear that food. They lost their milk out the front of their mouth, and they had panic reactions when the milk was even placed in their mouth, which shows great concerns for oropharyngeal dysphagia and aspiration. The study participants all had oral sensory motor dysfunction, meaning they had difficulties moving their structures in their mouth to control the food and to chew and eat it. It increased their feeding time, which means they probably lost more energy, and that is going to prolong their nutritional recovery, which is why we are concerned about the feeding skills for this population. Poor oral motor control, poor coordination in the oral preparatory phase places children at risk of oropharyngeal dysphagia. These feeding difficulties can further be exacerbated by respiratory symptoms and lethargy related to TB and HIV as well, and also the symptoms of COVID-19. Risks of oropharyngeal dysphagia do warrant dietary consistency modifications for the prevention and for stopping prolongation of nutritional recovery, as well as relapse for SAM. And we can see that there are specific concerns for oropharyngeal dysphagia because the children in their pharyngeal phase of the swallow, which is after the swallow is triggered and the food's going down, the children showed coughs and wet vocalizations. So we have established that there could very well be concerns for feeding skills in this population, and it needs more research. In the communication assessment, we showed that there was an atypical communication profile because there's a mild to moderate receptive expressive language delay. So a child is supposed to understand more words than they can say, but these children were able to say more words than they can understand. They also had specific difficulties in interaction attachment, gestures, play, and language comprehension. The mothers reported frequent ear infections, however, no ENT referrals were reported. And when we asked the mothers, they perceived their children's speech development to be A-OK because their children were apparently too sick or too small to speak. And that raises a big concern for our ability to identify these children and provide early communication intervention because the moms are not concerned about their communication. And we are relying on them to tell us that they have concerns. Okay, so when we were identifying cases for this research, it was really unexpected to find HIV and TB co-infection, and we made the following observations. The moms were reporting short breastfeeding duration, PMTCT failure, poor adherence to baby wellness consultations, and delayed diagnosis of onset of HIV and TB, which only occurred at the hospital, and treatment was only started at the hospital. These are things that we typically rely on the clinic to identify and manage, but the mothers didn't attend the clinic, and they cited that their fear and their difficulty social distancing in the transport were the reasons that they didn't attend. So we can see that the COVID-19 socio-behavioral strategies that were implemented did impact how these mothers access their healthcare, and it shows that there is a disruption to the services that were provided. They might have been identified and treated earlier. This delayed identification is going to perpetuate the quadruple burden of disease in South Africa. And so going forward for future practice, we need to be very aware of how these strategies impact the way our patients seek their healthcare. So to close, I want to highlight that firstly, the complexity of SAM with TB and HIV co-infection requires teamwork. The novel description of oral sensory motor skills for feeding and oropharyngeal dysphagia for children with SAM, as well as their atypical communication development, highlights the need for further research to inform the role of the speech therapist. And lastly, PMTCT failure, poor adherence to baby wellness consultations, late diagnosis of HIV and TB, and prolonged time before we actually implemented their treatment, even though the moms were aware of their own diagnoses, highlights that our primary healthcare was disrupted by these socio-behavioral strategies. And going forward, we need to be aware of that effect so that we can advocate for our patients. And then that is it. Thank you very much. And I really appreciate your time and being here to listen. Thank you.
Hello, good morning. Thank you so much, Casey, for your presentation. I'm so sorry that we seem to be having some technical difficulties. So I was actually in this session and trying to reach out to everyone, and I thought the issues were on the other end, but I think they were on my end. So, but not to worry, just a bumpy start to this morning, maybe even comical, but in the room now, and I'm so glad you did get a chance to get started and give your presentation. Yeah. I caught just the tail end of it, I would say. I'm so sorry I missed the first half or maybe more of it, because I do have a personal interest in this, being that I'm also, or was, a child who was brought up multilingually. So I find that very personally fascinating. Yeah. But maybe I'll go back, since these sessions are being, this is a good time for me to mention that the sessions, all of the conference sessions are being recorded, and they will be available for the duration of a year. So I might come back and revisit your presentation for myself. Yeah, and I also wanted to, I did give your intro, but apparently I was the only one able to, see my video and hear my audio. So I'm just going to do that now, if that's all right. Just
that's
so
no problem. Thanks.
Okay, great. Just so everyone's familiar. So Miss Casey Jane Eslick is currently a speech language pathology lecturer at Sefako Makato Health Sciences University and a doctoral research student within the Department of Speech Language Pathology and Audiology at the University of Pretoria. She has obtained a master's degree in speech language pathology, focusing on the early literacy skills development of multilingual learners. She has gained experience in the public healthcare sector while working at Cecilia Makiwane Hospital in Mdantsane Township in the Eastern Cape, as well as supervising schools and community engagement practicals for speech language pathology students. Her primary interest is in early communication intervention for young children. So again, a fascinating topic that you study for me personally. And I just want to see if we have any questions here. Oh, and quickly, I'm Dilshad Tung. I am the session chair this morning, and I work with the Tygerberg International Secretariat. So just my quick intro there. Let's see. We have one question here from Dr. Nyambura Mogiru. She thanks you for the most interesting presentation. And her question is, in view of the challenges in access to health resources experienced during the COVID-19 pandemic, what have you found were the implications of this for your findings?
So we specifically, thank you so much for the question. We specifically were just looking at trying to summarize and state what it is that the children are presenting with when they get to the hospital. What are their developmental skills? And we happened upon the fact that they have had this disruption and that the implementation of healthcare for them was so delayed. And so what we're finding, if we compare to previous research, it's not specifically our own, but in terms of our research investigation, the literature has informed us that if they had had their healthcare earlier, they might not have even been diagnosed with SAM, because HIV and TB are significantly contributing to a child's willingness to eat and willingness to engage with their family around them. And if you are having better engagement at home, and if you are having a child that's willing to eat, they're going to get nutrition, which means they'll gain their weight the way that they should, and they might not end up with SAM at the end. And I'm not a doctor, please note, I'm not a doctor. So I'm not exactly sure how it works, but what's being explained to me at the hospital is the fact that the way that HIV works with a child and impacts their neurodevelopment and their health, that is actually impacting the child's willingness to eat as well. And their ability to want to eat and their body's ability to use those nutrients as well, once they've eaten, and how those nutrients are absorbed is impacted by the fact that their body is fighting HIV. So if they had had that treatment earlier, if they'd been able to get services at the clinic earlier, there's a small chance that they might not have been diagnosed with SAM, and they could have been managed at home at the clinic rather than being admitted to hospital. So in terms of access to healthcare resources, it's more the fact that it stopped us from doing prevention. If our children had come to the clinic, we would have been able to do our normal identification, starting on treatment, monitoring, but these moms didn't come for their checkups. So unfortunately, the COVID-19 pandemic has really stopped us from being able to prevent and monitor at an earlier stage. Yeah.
Thank you so much, Casey. Yeah, I mean, I think as time goes on, we just keep, unwrapping, I guess, or uncovering so many more impacts and consequences of this COVID pandemic that, I don't know that most of us could have foreseen, but you've illustrated an example of one such, consequence right there. Yeah. So, yeah, thank you. And then we have a question. I'm sorry, I missed your first one, Emma, but I'm going to just, and I see you have a second one, so I'm just going to share those both now with Casey. So Emma says, thanks for your presentation. I want to ask how difficult it was to get participants. I just know the German perspective, it is a lot of bureaucracy here.
Okay, so in South Africa, it's a little bit of a concern actually, but in South Africa, when children are admitted to the hospital, in a government hospital where I was doing my research, once you've gone through the process of getting permission from the hospital management and from the whole district Department of Health, if you then collaborate with the doctors in the hospital, they see your research as providing further services to their team and also to the client. So the hospital staff then are actually very willing, once you've got all those permissions that you need to, they're very, very willing to help you identifying patients, so long as you have followed the correct procedures to get consent in the first place from all the stakeholders. So I was very lucky. There was a lovely doctor team. They introduced me to the doctors that rotate each month and gave me their contact details. And the dietitian phoned me each and every time she identified someone in her ward to say, please come, there's a patient for you, because they realized that these patients weren't getting speech therapy services before they went home. And so if they could refer to me, they were excited because it meant that I then referred to the actual speech therapy department. So they could see the contribution, and because of that, they were very willing to help me identify my participants. But it did take me, given that there was also COVID, it took me about 18 months to get my clearance from the overall hospital and the Department of Health in the province. So it took a good while to get the initial consent, but once I was in the hospital, I was getting referrals literally every 2-3 days, which was wonderful. Yeah.
That is wonderful. So maybe two things there. One is to start early in terms of getting those permissions for yourself. And then also it sounds like just having the buy-in from the hospital or whichever service providers that you're working with seems to be a huge benefit just to the researcher. So maybe that gives you some ideas, Emma, if you're going to be approaching any of that kind of research soon. And then Emma's other question was, she says, I can imagine that it was not always easy to be professional. Can you tell me something about the experiences you made during working with the participants and the results?
Thanks for your questions, Emma. I think for me, working with this population is my professional. I think we all have a professional personality, and I find it very natural and easy. My passion is in public health. But I think the biggest challenge for me was language barriers, because many of the moms coming in don't speak English well. And I'm asking them questions that are not the English language they usually use in conversation at work or with their friends. So I have to ask them very specific language aspects, like how many words can your child say? And I had to ask them, when you show your child a mirror, what do they do? And those are words and phrases and questions that they're not used to. So I think the hardest thing for me was to become a little bit of a comic act and demonstrate to the moms what I was asking them. And then at other times, it was actually easier to jump in with the mom and help her play with the baby to see whether or not the baby could actually do that, because eliciting it from the child with the mom's help is easier than trying to explain to the mom, and then I get reliable information. So yeah, I think there were a couple of challenges, but at the same time, things that I really enjoyed doing. Thanks.
Thank you for that response, Casey. Yeah, I think even for any of us who have had to travel to countries or regions where we don't speak the language, we find that body language helps a lot. There's just a certain universal body language gestures that I think are very useful. It sounds like you kind of engaged in the same.
Yeah.
We have another question from Dr. Niambora Mwagiru. She says, thank you, Casey. As a brief follow-up, I believe, to the first question about COVID-19 implications, what do you foresee will be the impact on this critical need for child nutrition and access in view of the environmental impacts on current food production? So what responsibility do you think public institutions have to ensure access to health resources for this group of people in our community?
Well, firstly, I think we've made one of the most important steps, which is changing SAM management from just the hospitals to the communities, to the healthcare clinics as well, because it then becomes the clinic's responsibility to monitor and make sure that each baby that comes to them is being checked and identified and weighed and measured. And I think that responsibility, that change from just being the hospitals to the clinics already has been groundbreaking. And we're seeing that it's working. The research is slow because the change only happened about 10 years ago. So the research is slowly starting to come out now that there's been time to implement these ideas. But I think that was the first big thing that has really changed the distribution of responsibility. And then for me, I'm finding that one of the biggest concerns is to make sure that the team in the hospitals feels the responsibility to refer to a speech therapist, because if a child can't eat correctly, they can't get that nutrition. So before they go home for further management at the community, at the clinic, they need to be identified to know, do they have the oral motor skills to eat or not? So that is something that is going to become not just the hospital team's responsibility, but we need all stakeholders to take up this information now and start spreading it further, because it isn't in the guidelines. It isn't in the publications about SAM. We need the departments of health to take this up and to put it into their recommendations and give those instructions to the hospitals as well. Related to food insecurity specifically, we need programs where moms can come and report to the clinics and not just the hospitals to get support, because when they're looking for support with how to access food or money for food, they have to go all the way to the hospital. And that's where the social workers are. There's very few of them at the clinics. And yes, they're walking around the community, but they don't get to everyone in time. So the moms are having to spend the money that they need for food just to come to the hospital. And that is a big problem as well. And I'm not public health. I don't have that solution yet. But at the same time, I do see that as a big concern. And it's something that in our larger study has been raised by a number of mothers. So yeah, I see it. It's everyone's responsibility. But I think the biggest thing for public institutions is going to be training their staff that they are training and sharing this information far and wide in all the publications that they're making. Yeah. Thank you. It's something I need to do more thinking on.
No, but I think, I mean, your answer there is quite, it sounds like a helpful one, or at least one that can start the conversation, or, even start ideas like implementing further training you mentioned. And it sounds like just education sharing, information sharing is really important as well. Especially it sounds like in terms of getting these services out into the community, to circumvent the issue with access, with mothers having to travel to the hospital. So yeah, really, really insightful, I think. So thank you for that, Casey. All right, that's it for those questions. I'm just going to, well, thank you once again for your presentation. It was a really engaging bit of dialogue we got to have here too in our Q&A session. So thank you once again, Casey, for that. And then we are just going. All right, great, thanks. Sorry, go ahead.
I was just saying thank you so much, and it's been lovely to be here.
Wonderful. It's been lovely to have you this morning. All right, we're going to move things right along to our second presentation, which is going to be given by Mr. Christopher Likando from Stellenbosch University in South Africa. His presentation title is Towards High Quality Lower Limb Prosthetics Service Delivery in Namibia, Adherence to Global Policy Standards. And Mr. Christopher Likando has 20 years of experience working for the public health sector in the Ministry of Health and Social Services in Namibia, currently heading the Division of Disability Prevention and Rehabilitation in the Primary Healthcare Directorate under the Ministry of Health and Social Services. He is currently pursuing a PhD at Stellenbosch University in Health Sciences Rehabilitation. He holds a master's degree in biomedical engineering from the University of New South Wales in Australia, and a Bachelor of Science degree in prosthetics and orthotics, and a diploma in orthopedic technology, both obtained in Tanzania, respectively. He has served as the Ministry of Health and Social Services in various clinical and administrative roles. While at the MOHSS, he participated in revising several policies, guidelines, and other documents. He serves also as a member of the Allied Health Professions Council of Namibia and a member of the International Society for Prosthetics and Orthotics. So thank you very much, Dr. Likando, Mr. Likando, for joining us this morning. We really appreciate you being here and giving your presentation. So I'd just like to extend a warm welcome to you, and I will pass things over now.
Thank you so much. Are you able to hear me?
Yes, we can hear you clearly. Thank you.
Oh, thank you. Are you able to see my screen that I have shared?
Yes, we're able to see your slide. Thank you.
Thank you so much for the opportunity. My presentation this morning is entitled Towards High Quality Lower Limb Prosthetic Service Delivery in Namibia, Adherence to Global Policy Standards. I want to move the slide to the next, but it's not moving.
You could either use the arrow key on your keyboard, or there should be, a small button that you can click on your PowerPoint window. You can see the arrows there. There you go.
Yeah, this is fine now. Yes, back in 2017, the World Health Organization, in collaboration with the ISPO and USAID, published the prosthetics and orthotics standards, which is meant to improve prosthetics services in countries around the world. The WHO recommends that each country in the world should be able to compare these standards that were developed with the national prosthetics and orthotics systems so that to create a benchmark from which to monitor further development. The provision of lower limb prosthetics is very important to global health because it improves mobility for the user. It also improves the ability to do daily activities as well as creates independence. That concurs with the definition of healthy, which includes physical, social well-being, and mental well-being. Therefore, for one to be fully healthy, you need to be mobile, and that's what the lower limb prosthetics creates in an individual's life. In Namibia, so far, there is no data available for prosthetic service delivery, from which we can be able to compare with the global standards. That's why this study was initiated. The aim of the study is to explore the status of lower limb prosthetic services in the healthcare system of Namibia and compare with the WHO global standards. The focus of the study was on policy, products, personnel, and provision. The presentation for this morning will mainly focus on the first part, which is policy, and the main objective is to compare adherence of policies, national plans, and funding with the WHO policy standards. The methods that were used in this study were mixed methods exploratory design, where I looked at qualitative and quantitative data which was collected and analyzed sequentially. The data was collected mainly in the Khomas region and the Oshana region of Namibia. The Khomas is regarded as urban, and Oshana is mostly rural part of Namibia. There was no much good records of patients in this regard. That led to the data being collected to be non-probability. It led to non-probability sampling from both settings and phases. The qualitative data that was collected, it was semi-structured, audio recorded, interviews that were collected from 2 service managers of the centers in Khomas region and Oshana, and 9 prosthetics, lower limb prosthetics providers, and 16 lower limb prosthetic service users. The quantitative data that was collected, it was collected from the same 2 service managers, 10 lower limb prosthetic service providers, 120 service users. The survey was developed for managers and providers, whereas the service users, a Trinity Amputation and Prosthesis Experience Scales survey was used, which was revised in this case. Data was qualitative data was analyzed with using Atlas TI, whereas the quantitative data was analyzed descriptively using SPSS. Thereafter, the data from 2 phases was triangulated and presented together. Thereafter, the study revealed that from the 15 policy standards, only 2 of the standards were well implemented, standard number 5 and number 6. And 7 standards were partially adhered to, while 6 of the standards were not implemented at all. When we look at the 15 policy standards, the findings showed that indeed there are policies that are available in Namibia that influences the provision of lower limb prosthetics. But unfortunately, these policies, they are not up to date. They do not respond to current needs and current practices. The funding was found that it's available on an annual basis, but it's not usually sufficient to meet the needs of service users. The results also showed that the service users are not usually well involved when it comes to policy in development, planning, implementation, monitoring, as well as evaluation. But it is very important for service users to be involved because they can provide valuable inputs because they are the users of the service. It was also found that there's no national prosthetics committee. The availability of a committee is very important as it can such a committee can ensure that policies are well monitored and they are well implemented. And the committee can also ensure that service users are involved, but there is no such a committee. Data is not usually stored in a database. There is no database available for prosthetic services from which decisions can be made. Data collection is usually sometimes collected, sometimes is not collected in regard to prosthetic services. Universal health coverage in Namibia is not fully implemented, but there are plans to do it, and it's positive. There is willingness from healthcare providers to implement universal health coverage, as well as our there is also a political will. In conclusion, the study showed that there are few positive efforts towards adherence to policy standards. 6 policy standards were not well implemented at all. Therefore, that shows that more efforts are needed towards improving the delivery of these services and bringing them to a level that is in line with the WHO standards. Based on the study results, it was concluded that 10 P's or 10 factors that are used in system thinking of assistive technology were suggested as a model for prosthetic service delivery in Namibia. The 10 P's, they look like this. Service users, or the people who are using the services, they are the main, they are at the center of all this. The whole focus should be concentrated on them. And all other factors should also be considered to ensure that services are well delivered. And these are the recommendations from the study. These recommendations may also be applicable in other settings in Africa or probably other low and middle income countries. There should be national prosthetics committees established. Governments should ensure that strategic and annual plans includes prosthetic service development. Prosthetics and rehabilitation services should be given the same priority that is given to other healthcare services. There should be a good allocation of funds for the procurement of products that are needed for these services. Policies should be developed comprehensively and be revised periodically. Government should ensure that the service users are well involved in planning, development, implementation, monitoring, and evaluation of services. Those are some of the references that were used in this study. And I would like to thank you for listening. And this is time for questions. Thank you so much.
Thank you so much, Mr. Likondo, for that presentation. I just see that we have a note in the chat box from our organizer. They're asking you to please stop your screen share so we can see and hear you more clearly for the Q&A. All right, I'll give you a chance to do that, and I'll just check if we have any questions coming in. Not just yet, but I actually had a question. Oh, there we go. Thank you. I actually had a question as you were going along. In one of your earlier slides, you mentioned that the policy standards are not being implemented thoroughly. I think it was 2 out of 17 or something like that, which is pretty low. So I was going to ask, if you had a sense of any reason for the poor adherence, but you seemed to answer that as you went along. In your presentation, it sounds like that from what you said, that the policies are really not responding to the current needs, and they're not keeping up with the modern needs. So I was curious, in your professional opinion, what would a set of policies look like? What would that include in a set of policies that are responding to the more modern needs of this population?
Well, when you look at the WHO standards, first of all, the policy is supposed to, before they are developed, they need to involve service users, because service users know them, they know very well what is required from them, and they know the services that can be very good for them. And then in that regard, policies supposed to include good funding, and they're supposed to look at the type of products that the service users need in the country. Some products are quite expensive, but they are of good functions. But we're supposed to look in countries like Namibia, we're supposed to look at products that are affordable, but they can also provide good functions. So our policies should address all those factors. Policies should also look at issues related to availability of facilities, good facilities for service users, because most of the time we see that the facilities are only available in urban areas. They are not available in rural areas, while majority of our population, especially those with disabilities, they are mostly living in remote areas, areas that are difficult to reach. Therefore, our policy should ensure that facilities are available in rural areas, of which they are not available now. So those are some of the aspects that should be looked at. Yeah.
Thank you. Yeah, that's a pretty thorough answer. I mean, you've already thrown some potential solutions at anyone who might be looking to rewrite that set of policies. And I think a big one that you mentioned that seems to be recurrent, I would say, across disciplines as far as WHO policies go, is really taking into account and responding to the context, right, where the service users are. So you mentioned that, the difference between the rural and urban access to these treatments. So thank you for that. And we just had a comment from Casey Jane Eslick, our other presenter. She just says, thank you, Mr. Likando. It was a very interesting presentation. You answered my questions as well. So I think you did a very thorough job in your presentation there, Mr. Likando. I'm just going to check if there's any other questions here. Any other questions from our audience? I don't see any other questions here. Do you mind telling us maybe a little bit more for those of us who are also still studying or might be going back to studying, a bit more about maybe some of your current research that you are doing or maybe plan to do as part of your doctoral studies that you're endeavoring in currently?
What I'll be doing from now onwards, because my study was looking at 4 areas, which is policy. It was also looking at products, prosthetics products. It was also looking at personnel, Those are the professionals involved in prosthetics and orthotics. And it was also looking at provision of prosthetic services in general. So what I'll be focusing on now is to publish articles, 4 articles that are related to the 4 areas. The first article will be on policy. The second article will be on products. The third article will be on professionals involved in prosthetic service provision. And the last article will be looking at the provision of prosthetic services in general. So altogether, we we have 60 standards for prosthetics and orthotics. Policy is only looking at 15 standards, whereas products, there is 9 standards. Personnel, there is 12 standards, and the last one consists of 24 standards. Altogether, there are 60. So I'll be looking at all 60 standards in general out of, if I manage to publish all the four articles.
I'm sure that you will. I think it's interesting, and it speaks well that you're what you're endeavoring to study now will just further answer, I think, some of the questions that have emerged maybe from your previous research as well. So I think that's generally the idea with research, but it's just interesting to see that, even with a single researcher, we can start to uncover so many answers, not obviously uncover many questions, but then as we continue, just answer those questions as well with that research. So that's really interesting to see in action. And then we have just a message from Dr. Keith Martin. He says, thank you, Mr. Likando. Access to quality prosthetics is a huge and neglected area. See DREV for some potential ideas. They develop such prosthetics. So that might be something to look into there. And a question from Dr. Niambura Magiru is, what are the potential impacts of technology and artificial intelligence on the future of prosthetic developments?
What we are looking at is that with the use of technology, we are very sure that these services, they are going to definitely improve. You have seen the use of technology when it comes to lower limb prosthetics for athletics. You have seen how athletes are doing, how good they can run. Some of them can even do better than able-bodied individuals. So you can see that the use of technology is doing very well. But at the same time, we are only scared of the cost that it comes with. If you make good use of the technology, you are going to get good results. But at the end of the day, you are going to end up having high costs involved, of which that is a worry in low and middle income countries to have unaffordable prosthetics products. So we want to ensure that in as much as good technology is being applied, there should be cheaper products that are available for low and middle income countries, so that service users can have access to good prosthetics through the good use of technology. So that's what we are looking at.
Thank you. Yeah, I think that's an important note to include, just about, future technologies and treatments in general, especially as it relates to health, is considering the equitable access to people who need it across contexts. So a really important point we need to remind ourselves of. And then Keith Martin has shared the link there. Mr. Likando, if you wanted to access that, drkfoundation.org is the site for Equalize Health, which was formerly DREV, if you would like to keep that for your records. And I don't see any other questions, but we've had a couple of great, engaging presentations here just in this one session. So thank you once more to both of our presenters for the work that you've done, the research you've done, and that you continue to do, and the knowledge that you're bringing to the field of global health. And thank you so much for being a part of this conference with your presentations. We really do appreciate your participation in the work that it takes, you know, outside of everything else and your other work that you're doing, to take the time out to present to us and to share your knowledge. So
thank you so much. Thank you so much for giving me the opportunity. I'm sure that it will also, you'll also give more opportunity to others.
Yes, definitely. We hope to do that. But then that's a perfect segue for me to remind everyone that we value your feedback, and we would like to continue to bring you programs such as this one. So please do remember to complete your evaluations for the conference. You'll see those in your email. They'll also pop up for you. They've popped up for me in my notification bell in the top corner of my screen. So please do complete those. And I'll also remind everyone that all of the conference sessions this weekend are being recorded, and they will be available online for future access for the duration of a year. So you can always come back and check in with sessions that you might have missed or want to revisit. And just as a quick note, we did have Ms. Rachel Smith scheduled to present today, and unfortunately she had to let us know last minute that she had a family illness to deal with. So we wish her and her family the best. So hopefully she will join us for a future program. All right. Thank you so much again, everyone. And with that, I will be closing the session. And we welcome you and encourage you to join some of the rest of our sessions going on today. Take care. Thank you.